تفضل.
Thank you, Rad, for the introduction. So this is part 2, and part 2 of bone tumors. You may remember in part 1 we talked about non-neoplastic tumors and the cartilage tumors or the chondroid tumors. Part 2 we will focus on other types of cell origin of bone tumors, which include osteoblastic tumors, osteoclastic tumors, and marrow tumors. So just really to reiterate what we talked about in the previous talk is the primary mainstay for bone tumor description is radiographic. So radiographs are the first imaging test for primary bone tumors, and your differential diagnosis should always be based on radiographs. Cross-sectional imaging is only used as a problem-solving tool, and MRI is used for local staging. And we said in the previous talk that when we comment on the radiographs, we will always comment on the age of the patient, the site of the tumor, the pattern of bone destruction, whether it's lytic, sclerotic, or mixed. Multiplicity of the lesions are very important. Multiple lesions normally would imply other entities such as multiple myeloma or metastatic disease. We would always comment on the presence or absence of cortical destruction, periosteal reaction, and what type of periosteal reaction. Is it sun rays? Is it Codman's triangle? Is it onion peel periosteal reaction? And that also determines the nature of the bone tumor, whether it's non-aggressive or aggressive bony lesion. The presence or absence of extraosseous mass is very important, and particularly in this second part of the talk, we will see examples of primary bone tumors that manifest as extraosseous mass. So this is always something we need to look for and comment upon because it really changes your differential diagnosis. Zone of transition is also important. We mentioned that narrow zone of transition implies a benign lesion. Wide zone of transition implies an aggressive bony lesion. The presence of industrial scalloping is also important. We saw this pattern of bony destruction in chondroid tumors because chondroid tumors are normally lobulated. They form a lot of cartilage, and the cartilage will be seen as industrial scalloping on the radiographs and CT. Also, if the lesion is expansile or non-expansile is very important. And we saw examples of aneurysmal bone cysts, for example. And also we went over the distribution. We referred to this schematic representation of bone tumors and the distribution of bone tumors. We looked at bone tumors that are epiphyseal, metaphyseal, cortical, intramedullary. And this is a very, very useful guide for describing or trying to narrow down your differential diagnosis. We also commented on the metaphyseal part of the bone and how active this area is because of the vascularity and how dynamic this part of the bone is. We divided the metaphyseal part of the bone into the osteoclastic zone and the osteoblastic zone because each zone contains different types of bone cells and therefore different types of tumors. So as we mentioned earlier, we will be talking now about the osteoblastic, osteoclastic, and marrow tumors. We will start with the osteoblastic tumors. So I have a case here for the residents. If anyone can volunteer and take this case.
دكتورة دينا.
نعم أستاذ، صباح الخير.
صباح الخير.
leg X-ray, AP and lateral, showing an osteolytic, cortically based osteolytic lesion with a surrounding area of sclerosis in a patient with skeletally immature skeleton. A narrow zone of transition, no destruction, no bone destruction, seems no associated soft tissue mass. The picture is highly suggestive of osteoid osteoma.
Yeah, fantastic.
The differential that.
Sorry, go on.
The main differential diagnosis is Brody's abscess, but the picture I'm seeing is fairly typical of osteoid osteoma.
Yeah, fantastic, excellent. Yeah, so it's osteoid osteoma, and osteoid osteoma radiographically exactly how you described it. It's a cortical-based lesion with a nidus, which is normally radiolucent, surrounded by intense sclerosis. So this is typical appearance of an osteoid osteoma, and you made very good observation. This is a child because we can see the growth plate, skeletally immature. The distribution of osteoid osteoma in the skeleton, most of the times we really see it in the long tubular bones, and femur is the most common location for osteoid osteoma. After that comes the tibia, as we can see in this patient. It can also be seen in the spine. Although the most common location for osteoid osteoma is cortical, there are case reports of intraosseous or cancellous osteoid osteoma, and this can be very challenging. Sometimes we see that I've seen probably 2 or 3 cases of intraosseous osteoid osteoma, and can be really difficult, and they normally present as focal area of intense edema within the bone, and they don't really have the cortical thickening or sclerosis that we typically see with cortically based osteoid osteoma. So bear in mind that osteoid osteoma can be entirely intraosseous in about 25% of the cases. On CT, again, it will just really show you the same thing. It's a radiolucent or a lytic center surrounded by sclerosis, as we can see in this patient. Sometimes you may see periosteal reaction. It is very important that we measure the size of the nidus. Nidus normally is less than 1.5 centimeter, and this is very important when we talk about osteoblastoma, because if the nidus is more than 1.5 centimeter, that will make it osteoblastoma rather than osteoid osteoma. And by definition, osteoblastoma is just considered as a giant osteoid osteoma. Sometimes the nidus may mineralize, and mineralization in some of the research articles, they suggested that the presence of mineralization indicates that the osteoid osteoma is probably burnt out or died altogether. You can also demonstrate osteoid osteoma on bone scan, and on bone scan, there's a description of the typical appearance of osteoid osteoma on bone scan as a double density sign. And the double density sign indicates the presence of the activity within the nidus, and then surrounded by a large area of less intensity because of the sclerosis. So sometimes this comes up in the exam, the double density sign appearance of osteoid osteoma on bone scan. On MRI scan, we will see the nidus, and the nidus is normally high signal intensity on T2 and intermediate signal intensity on T1. Because this osteoid osteoma is close to the joint, sometimes you see joint fusion and synovitis. We talked about the disproportionate edema in the previous talk, and we said differential diagnosis for primary bone tumors with disproportionate edema includes tumors such as chondroblastoma, osteoid osteoma, Brody's abscess, and osteoblastoma. And we can see the same thing here. We see a lot of edema for a small lesion. There is a lot of edema that is very disproportionate to the size of the tumor. So always remember this differential diagnosis list for disproportionate edema. There's been also some research about doing dynamic enhancement for osteoid osteoma on MRI. We don't really do it in our center because we don't feel it is necessary. And it is only useful in cases, for example, where you're not sure if this is a Brody's abscess or osteoid osteoma. You could actually do dynamic contrast enhancement on MRI, and you see on the dynamic enhancement peak of enhancement and then early partial washout. So the MRI scanner should actually generate a graph. We normally ask the MRI technologist to draw the graph for dynamic contrast enhancement. Also, you may see periosteal reaction or periosteitis with osteoid osteoma on MRI. As I mentioned earlier, if the osteoid osteoma is very close to the joint, you will get joint effusion and synovitis which is just reactive to the presence of osteoblastoma. Management of osteoblastoma can be done image-guided radiofrequency ablation or laser-guided ablation. So this is something also in the exam. If you're presented with osteoblastoma, you can always comment on recommendation for referring this patient to interventional radiology for radiofrequency ablation or laser ablation. Differential diagnosis for stress fracture, as you mentioned, Brody's abscess is probably number one differential diagnosis for osteoblastoma, but also stress fracture can look like osteoblastoma, as in this case. And the presence of focal cortical thickening in the compressive zone of the tibia, for example, here, is typical location for stress fracture. You also can see from these radiographs, we don't really have a radiolucent nidus within it. So this would be more likely a stress fracture rather than osteoblastoma. What you can do as well is to try and repeat the radiographs after activity modification. So if this is a runner or a jogger, you can ask them maybe to stop running for about a month and then repeat the radiograph. And we have done this with this patient. We're repeating the radiograph after activity modification, and the stress fracture completely healed and disappeared. You can use bone scan as well, but bone scan is confusing because both osteoblastoma and stress fracture will appear hot on bone scan. So it doesn't really help you differentiate stress fracture from osteoblastoma. And you can also use cross-sectional imaging to differentiate between osteoblastoma and stress fracture. So on CT, for example, you can see the linear fracture line. There is a lot of periosteal reaction surrounding the stress fracture, which is not usual to see with osteoblastoma. So this will make it more likely stress fracture rather than an osteoblastoma. Okay, now we move on to the next case, and if we have a volunteer. This one is difficult, so don't feel too intimidated by this one. I will help you, but it's just really a guide for our next topic.
دكتورة إيناس طاهر.
نعم، صباح الخير.
صباح الخير.
صباح الخير.
X-ray of the pelvis AP view show lytic lesion بالright sacral. يعني تبين كأنه narrow zone of transition. No soft tissue extension. But no cortical destruction.
Yes,
Okay.
absolutely. You did really very well. I'm very impressed. Yeah, I'm really impressed that you detected the lytic lesion in the right sacral ala. And you can see the asymmetry between the left sacral ala and the right sacral ala. I agree there's narrow zone of transition. What's your differential diagnosis?
يعني إنه skeletally mature، فأول ما أخلي ببالي يعني lytic lesion metastasis.
Okay, yeah, that's metastatic lesion for sure. Yeah, we can have that in the differential diagnosis. So remember, the topic of our talk is osteoblastic tumors. What
osteoblastoma.
Yeah, osteoblastoma. Yeah, so this is the CT scan corresponding to this lesion, to this radiograph, and we can see, yeah, go on.
Well-defined lytic lesion with the narrow zone of transition. يعني هي هاي نايدس تكون أكبر من 1.5 cm وليتل إنه sclerosis surrounded by sclerosis. يعني هي الفيتشر تمشي ويا الأوستيوبلاستوما.
Yeah, fantastic. Yeah, absolutely. This is osteoblastoma. And the reason why I actually presented these radiographs, because osteoblastomas are very common in the postural elements of the spine, as we saw in this patient. So yeah, absolutely quite rightly what you said about the size of the lesion is more than 1.5 centimeter. The size of the nidus, which makes it osteoblastoma rather than osteoma. It's a lytic lesion, sometimes can be expansile if the lesion is present in a tubular bone, for example, in the humerus. Location in the spine is very common, more than 60% in the posterior elements. On radiographs can be lytic, circumscribed, and expansile lesion. On CT scan, as you described it quite rightly, is a lytic lesion with narrow zone of transition, less amount of sclerosis compared with osteoma, and commonly see it in the posterior elements of the spine. On MRI scan, the signal intensity is similar to osteoma. So you will get like intermediate signal intensity on T1 and hyperintense signal intensity on T2. Sometimes you see signal void within it. That's due to the presence of calcification. And we said the same thing about osteoma. Sometimes the presence of calcification within the nidus indicates that the lesion is not active anymore. And on MRI scan, again, we come back to this disproportionate edema to the size of the lesion. The lesion is really small, but look at the amount of osseous edema as well as the periosteal reaction, and even the soft tissue around the bone is very edematous. So that is what the appearance typically for osteoblastoma and osteoblastoma, chondroblastoma look like on MRI scan. And that's why we always rely on the radiographs for characterization of bone tumors rather than MRI, because MRI sometimes make the tumor look aggressive even for a benign lesion. Okay, now we move on to the next pathology. If we have a resident to take this case.
سجاء عامر.
نعم أستاذ صباح الخير.
صباح الخير.
صباح الخير.
X-ray of the knee, AP and lateral view. There is ill-defined, permeative, wide zone of transition, mixed lytic and sclerotic lesion involving the lower femur. There is an extensive periosteal reaction extend into the soft tissue. السكيليتال يعني mature skeletal. differential diagnosis يعني أول شيء أخلي osteosarcoma لأن pattern of periosteal reaction sunray appearance.
Yeah, absolutely right. Yeah, osteosarcoma. It's a lesion, an aggressive-looking lesion involving the distal femoral metaphysis. As you quite rightly said, there's actually even no zone of transition because it's quite extensive. I probably will add the extraosseous mass to your description. There is anterior and posterior extraosseous mass. What do you see within the extraosseous mass?
Ossification يعني higher density.
So what does that mean if there is ossification within the extraosseous mass?
يعني extra bone extension of the tumor.
Yeah, it's bone-forming tumor. Okay, because we will see later examples of other tumors that are associated with extraosseous mass, but not really mineralization. There's no mineralization. So this is the way we describe this one. We would normally say there is associated extraosseous mass with internal mineralization, because the internal mineralization within the extraosseous mass changes your differential diagnosis. So an extraosseous mass with internal mineralization indicates it's a bone-forming tumor. And a bone-forming tumor, like you said, with sunrise appearance, is normally an osteosarcoma. Yes, so this is osteosarcoma. It's an aggressive bone tumor. There is bimodal age distribution. This comes up in the exam quite a lot, which means that the patients who are affected by osteosarcoma, they are either under the age of 30 or over the age of 60. This is a very common phenomenon. We don't see it with other primary bone tumors, but we see it with osteosarcoma. The sun rays appearance, it makes it quite characteristic for osteosarcoma on the radiographs. The distribution, anatomic distribution around the knee is probably the most common location. About 55% of the cases are presented around the knee. They can also be seen in the flat bones, but it's not primarily a flat bone tumor. So I would just stick with a tumor that is seen normally around the knee. And the reason why we see it in patients older than the age of 60 is because of the presence of Paget disease or prior radiation, whether it's radiation for breast cancer, radiation for lymphoma, or radiation for pelvic tumors. There are 5 different types for osteosarcoma. The one that we just looked at, this example, is the conventional osteosarcoma, which is the most common one. 85% of these tumors are actually conventional osteosarcoma. Less common entities of osteosarcomas are the telangiectatic osteosarcoma, less than 5%, parosteal osteosarcoma, multicentric osteosarcoma, and periosteal osteosarcoma. So this is the conventional osteosarcoma. It is an aggressive tumor. There is quiet destruction of the bone, the moth-eaten or the permeative, as you said, appearance of the bony destruction. You see it sometimes Codman's triangle with it, or sunburst or sun rays appearance of periosteal action with it. The borders are very indistinct because of the extension of the tumor and the extraosseous mass with the internal mineralization. On MRI scan, also now I'd like to mention that with the primary bone tumor protocol, you always have to have the entire bone included in the MRI from joint to joint. And the reason why this is important, because it's a phenomenon that is seen with osteosarcoma. Sometimes you see skip lesions or skip metastases in the bone. And this changes the surgical management of the patient. So a patient, for example, who is presented with a tumor like this with no skip lesions in the proximal femur, they will have their surgery or the amputation, the surgical planning. But if they have multiple other skip lesions in the bone, then it will probably be a disarticulation of the joint rather than amputation through the bone. The signal characteristics of the tumor are really non-specific. They are either low or intermediate signal intensity on T1, and can be heterogeneous or bright signal intensity on T2 fat-saturated sequences. There is post-contrast enhancement. Sometimes you see cystic cavities within it due to tumor necrosis and hemorrhage. So yeah, again, what I really want to emphasize here is always in your protocol, you have to have the entire bone included in the MRI. Okay, we have another pathology. If we have another resident.
دكتورة شراء خالد.
صباح الخير.
صباح الخير.
AP and lateral view of the knee of skeletally mature bone showing medial femoral condyle of the femur looks, there is a ill-defined area with wide zone of transition and periosteal reaction. No soft tissue, little bone destruction, little cortical destruction, no surrounding soft tissue, يعني no expansion, no surrounding soft tissue extension. He looks malignant lesion. High in AP, يعني in AP there is a periosteal reaction, little surrounding cortical destruction. Lateral view يعني sclerotic, little sclerotic margin يعني from above and below. So يعني lesion maybe go with benign or malignant. يعني maybe osteosarcoma, or could be non-ossifying fibroma, since there is no extra bone destruction or soft tissue reaction.
Yeah, okay. So with characterization of bone tumors on radiographs, it's really important we either call it aggressive or non-aggressive. So even if the even if the lesion looked different on the frontal or the lateral radiographs, if there are aggressive features on one of the views, whether the AP or the lateral, then you just stick with that aggressive appearance.
With aggressive. And AP looks aggressive.
Yes, so if it is aggressive on the AP or if it is aggressive on the lateral, then it is aggressive. So you can't, so you can't have aggressive on one view and then benign on the other view. Yes, absolutely. So as you said, this is an aggressive bony lesion. There's cortical destruction, there's perosteal reaction, and the zone of transition is ill-defined here. It is a lesion involving the metaphysis and the medial femoral condyle. So this is the MRI for this patient. Can you describe it?
Yes. Also, there is a mixed, mostly cystic, with the fluid level, expansile lytic cystic lesion with the periosteal reaction, soft tissue edema. Here change maybe with differential here could be a giant cell tumor or aneurysmal bone cyst. هذا الفلويد level may goes with aneurysmal bone cyst, but since it is a skeletally mature and here it is an expansile lesion, so it may be giant cell tumor.
Yeah, okay, so if we try and connect this tumor with the topic of the pathology, we're talking about osteoblastic tumors.
Osteoblastic, yes.
Yeah, what kind of osteoblastic tumor would have these cystic appearances with fluid level?
The fluid level may be also osteosarcoma. If I connect it with the AP of the AP and plain X-ray, so it would be a variant of osteosarcoma. اللي هو telangiectatic osteosarcoma may be fluid level.
Okay, yeah, exactly. Yeah, so this is a telangiectatic osteosarcoma. And there are different other examples of telangiectatic osteosarcoma. It's less common than the conventional osteosarcoma, less than 5%. The prognosis is similar to conventional osteosarcoma. This is purely lytic. There is no mineralization. It's not a bone-forming tumor. This is the difference between telangiectatic osteosarcoma and conventional osteosarcoma. Conventional osteosarcoma is a bone-forming tumor. Telangiectatic osteosarcoma is not a bone-forming tumor. It's a lytic lesion with no mineralization within it. So just purely cavities with fluid level, with blood and necrotic tissue within it. It can look similar to aneurysmal bone cyst, as you said, but we will see how we can differentiate that. Normally, we would differentiate that with contrast enhancement. With ABC, what you see is actually smooth septation, but with telangiectatic osteosarcoma, you will see septation, but these septa will have nodular appearance or nodular enhancement. ABC, there's two types, there's primary and the secondary. The primary is completely de novo or idiopathic. The secondary one occurs on top of pre-existing lesions such as non-ossifying fibroma, chondroblastoma, giant cell tumor, fibrous dysplasia, osteoblastoma, and osteosarcoma. So this is the secondary type of ABC. Okay, let's move on to the other entity. Do we have resident?
دكتورة فرح قاسم.
صباح الخير.
صباح الخير.
This is AP and lateral view of the knee joint, showing sclerotic lesion involving the lower femur with extraosseous extension. And on the lateral view, we see there is extension of the mass to the posterior aspect. I see there is no evidence of bony destruction, non-cortical destruction, but there is, as I say, ossification within the soft tissue, mainly in the posterior compartment of the knee.
What do you call this?
Yes?
What do we call this pattern, the form of the lesion?
Maybe a type of osteosarcoma, and maybe paraosteal osteosarcoma. This is another type.
Yes, you are absolutely right. This is paraosteal osteosarcoma. It's less common than telangiectatic and conventional. It's about 3% of osteosarcomas are parosteal osteosarcoma. And the appearance is very, very classic. If they show you a case in the exam of parosteal osteosarcoma, it would look like this. It's a big lump of bone at the posterior aspect of the distal femoral metaphysis. Almost, I would say, probably close to 90% of the parosteal osteosarcomas I have seen in my career, they look like this lump of bone at the back of the femur. So this is characteristic appearance of parosteal osteosarcoma. They do have intraosseous involvement. The tumor is primarily paraosteal, but it also invades the bone within it here. The age distribution is older than the conventional osteosarcoma, as in patients between the age of 20 and 50. Remember, with conventional osteosarcoma, we said there is a bimodal age, but with paraosteal osteosarcoma, the age group is quite different. It's a low-grade tumor, is not as aggressive as the conventional or telangiectatic osteosarcoma. And on MRI scan, again, we see that pattern of bone involvement. So primarily the tumor is a large mass that sits external to the bone, but it then also invades the bone. So this is different to conventional osteosarcoma. With conventional osteosarcoma, what happens is the tumor arises from the bone and then explodes externally. But with paraosteal osteosarcoma, the tumor starts external to the bone and then invades the bone. So it's a different biology, completely different tumor biology. Differential diagnosis for paraosteal osteosarcoma is very important because I have seen cases that get sometimes mixed up, where paraosteal osteosarcoma is mixed with myositis ossificans. So here, for example, we see a lump of bone that is external to the bone, but is actually, if you look at it on cross-sectional imaging, there is what we call a cleft sign. And the cleft sign is what separates the mass from the bone. And also what we see is something we call zoning ossification or zoning phenomenon, which is a typical appearance of myositis ossificans, where the mineralization is more in the periphery than in the center. So this is called zoning phenomenon or zoning ossification, peripheral ossification and lucency within it in the middle. If you saw this on CT, you would call it myositis ossificans and leave it. You don't need to biopsy this because this is characteristic appearance. This is a benign lesion. This is one of these don't touch lesion. So no biopsy, nothing. You just leave it alone. Another differential diagnosis for parosteal osteosarcoma is synovial sarcoma. And synovial sarcoma is not a bone tumor. It's not even a synovial tumor. The name is a misnomer. It's a wrong name, but it's a name that stuck with the tumor forever. So it's not a bone tumor, it's not a synovial tumor. And on CT, it will demonstrate the reversal of the zoning phenomenon. So you will get more mineralization in the center, but less mineralization in the periphery. So imagine how this one looked like, the myositis ossificans, peripheral ossification and radiolucent center. Here's the opposite. Here is a radiolucent periphery, but mineralization in the center. This is typical appearance of synovial sarcoma. If you saw reversal of zoning phenomenon, this is definitely malignant, and this definitely needs a biopsy. Other differential diagnosis for parosteal osteosarcoma is parosteal lipoma. So also you will see a lump of bone that sits external to the bone, but then on radiograph, you will see some lucency within it. You do CT, and then again, you see this lipomatous mass with it. And on MRI scan, you will see this lipomatous lesion on T1, and which fat suppresses on T2 fat saturated sequence. So this is classic appearance of paraosteal lipoma. Another entity of osteosarcomas is periosteal osteosarcoma. This is really rare. I probably saw only one case in my career. It's 1% or even less. periosteal osteosarcoma. And what is really important here is to differentiate periosteal osteosarcoma from exostosis or osteochondromas. Remember what we talked in the first talk about exostosis or osteochondromas. They have corticomedullary continuity. Here with periosteal osteosarcoma, we don't really see corticomedullary continuity. We see just a tumor that arises from the periosteum with no corticomedullary continuity. So this is how we differentiate the two. So the last entity is the secondary osteosarcoma, which is about 5% of osteosarcomas. They are called secondary osteosarcomas because they occur on top of Paget disease, prior radiation, or bone infarct. Okay, so we are finished with the osteoblastic tumors. We are going to move on to the osteoclastic tumors. These are the tumors that arise from the osteoclasts, or the multinucleated giant cells or macrophages. The two entities of the osteoclastic tumors, the giant cell tumors, or also called osteoclastoma, and also the Brown's tumor. And these are the tumors that happen secondary to hyperparathyroidism. Okay, so let's have a candidate here and take this case.
دكتورة فرح سعد.
السلام عليكم. نعم أستاذ.
عليكم السلام، تفضل.
عليكم السلام.
عليكم السلام. X-ray of the wrist in skeletally mature patient revealed there is a well-defined osteolytic lesion in subarticular location of the radius. تقريبا يعني هو اكو بيتين ثابته واكو فد ببلي appearance. اكو فد cortical destruction دا اشوفها بالlateral side مال lesion. No obvious soft tissue extension. ف يعني narrow zone of transition probably. فممكن انه يكون يعني residual bone cyst, giant cell tumor.
Okay, yeah, that's correct. Yeah, so it's a subarticular location, subabal appearance, expansile lesion. This is actually pathological fracture.
نعم.
Yeah, it is very common to see pathological fracture in giant cell tumor. Okay, so this is giant cell tumor. The typical radiographic appearance is exactly what you described. It's an eccentric, lytic, subabal appearance with septation within it. Subarticular location is probably the most important radiographic appearance. If the lesion is subarticular like that in a skeletally mature patient, it's a giant cell tumor until proven otherwise. Sometimes you may see periosteal reaction within it as well. On MRI scan, it actually demonstrates these foci of low signal intensity, but predominantly the tumor is iso-intense or intermediate signal intensity. On T2 or STER or T2 fast saturated sequence, you will see this expansile appearance with fluid level with cystic cavities within it. There is high risk of or high chance of degeneration to secondary ABC, and particularly when you see cystic cavities within it with a fluid level, this would indicate there is degeneration of giant cell tumor to secondary ABC. It occurs in skeletally mature patients. Although it's a benign tumor, it actually metastasizes to the lungs. So this is kind of a bizarre situation where we have a benign tumor. This also comes up in the exam a lot. It's a benign tumor, but yet it metastasizes to the lung. So what that means is that if you saw this patient, you would need to do CT scan of the lungs, CT chest. We always send these patients for CT scan of the chest because of the risk of metastasizing to the lungs. And also after surgery, so what they do surgically, they normally curate the tumor and pack it with cement. But there is high risk of recurrence even after surgery. So you need to do regular follow-up on these patients with doing multiple radiographs. Differential diagnosis for subarticular lesions, as we mentioned in the previous talk, if the joint is degenerated, probably most likely what you're seeing is a degenerate cyst or geoid cyst. If the patient is skeletally immature, then we would be concerned about chondroblastoma. If the patient is skeletally mature, then there is a giant cell tumor, as we saw in this patient. But also in the differential diagnosis is a clear cell chondrosarcoma. Also has subarticular location. Now, we're done with the osteoclastic tumors because most of the times you will see giant cell tumors. Brown's tumor, I didn't give you examples of those because those are normally easy to diagnose. These are patients with renal failure who present with lytic lesions in the bone, and we just basically call them Brown's tumor. Now we move on to the other entity of primary bone tumors, and they are the marrow tumors. The marrow tumors include multiple myeloma or plasmacytoma, reticulum cell tumor or lymphosarcoma, round cell tumor, Ewing sarcoma, Langerhans cell histiocytosis, and metastases, although these are not primary, but I just left them there. Okay, do we have a resident to take a case?
دكتورة فردوس.
نعم عمي، صباح الخير.
صباح الخير.
صباح الخير.
عندنا AP and مو lateral، تقريبا احنا هنا نسوي magnification view. There is a destructive lytic lesion seen in the تقريبا ischium ball. اكو destruction in the cortex. يعني احنا باللاترال بوردر خلينا نقول هو يعني narrow zone، وهنا اكو wide zone expansile. اكو remodeling بالكورتكس. ما ادري اشوف اني اي سكليروسيس او calcification. extended to soft tissue. ما عندي اني هو mature مو immature.
So this is 13-year-old.
solitary يعني.
We can see the iliac crest epiphysis here.
What about the pubic rami? What about first the pubic rami? Right-sided pubic rami, superior and inferior pubic rami.
يعني أنا بدي أشوف هو multiple lesion. يعني أفكر بالإيوينج وبدي أفكر بالهيستوسايتوسيس بالسوبيريور ريماي وبالإلياك كريست بالليفت إلياك كريست. Also lytic lesion expansile وأكو cortical destruction.
Sorry, the left or right?
On the left.
You mean this one? Or
No,
this one?
superior.
This
superior.
One? Yeah, so this one is bowel gas, both of these.
يعني I see bilateral إنما bilateral iliac crest and superior and inferior pubic rami. شوية فوق iliac crest هنا فوق.
This one?
No, هاي يعني lateral إلها lateral.
Oh, this one?
هذه نعم يعني.
Yeah, this is the anterior superior iliac spine. It is normal, but again we come back to this really large lesion involving the acetabulum, superior pubic ramus, inferior pubic ramus, pubic bone, and ischium. So the whole thing is completely destroyed. And there is also, what do you call this?
يعني هنا هو expansile وأكو soft tissue extension. يعني تمشي ويا الإيوينج sarcoma.
Okay, yeah. So yes, so this is Ewing sarcoma, and really what gives it away is the age, and it's a tumor involving flat bone. So a tumor involving flat bone in a child is Ewing sarcoma until proven otherwise. So this is kind of how Ewing sarcoma looks like. Most of the ones that I have seen are actually either pelvic, scapula, or the ribs, where we find Ewing sarcoma. So the MRI scan for this patient, can you comment on the MRI?
Yes.
Yeah,
okay. There is a well-defined soft tissue lesion. هنا احنا عندنا بالهايبو بالتي 1 تقريبا ايزو بالتي 2 with avid enhancing the lesion and extension to the surrounding soft tissue involving نفس ما قلنا بالاكس-راي هي الاستابيولم and superior and inferior pubic rami. Mostly goes with the Ewing sarcoma.
Yeah, exactly. And there's also intra-articular extension of the tumor in the hip joint. There's displacement of the neurovascular structures. You can also comment on the, for example, sciatic nerve completely disappeared here. There's encasement of the femoral artery. So these are very important for local staging. This is the reason why we do the MRI. The diagnosis actually was based on the radiograph. We knew from the radiograph this was an Ewing sarcoma. The reason why we did the MRI scan is just to assess the local staging of the tumor. So always remember to comment on the neurovascular structures. For example, here the femoral vessels and the sciatic nerve. You can say, for example, I don't appreciate the sciatic nerve, so most likely there's involvement of the sciatic nerve. There's encasement of the femoral artery. There's displacement of the bladder. There's no fat plane between the bladder and the tumor. So all these are very relevant points because that is important for the local staging of the tumor. Yeah, so Ewing sarcoma is typically a tumor of skeletal immature patients. Predominantly involves the long and flat bones. More common flat bones involvement, pelvis, sacrum, and scapula. We can, if the tumor existed in the long tubular bone, it's most likely diaphysian in location. On radiographs, what we see is the onion peel or onion skin appearance, which is also characteristic of Ewing sarcoma. The signal characteristics are really non-specific. They are low on T1, high signal intensity on T2 fast saturated or stair sequence. And remember what we talked about the extraosseous mass when we talked about conventional osteosarcoma. We said the extraosseous mass contains internal mineralization, but when we look at the extraosseous mass for Ewing sarcoma, we don't really appreciate any internal mineralization. So this is a distinctive feature between a bone-forming tumor versus a marrow tumor. A marrow tumor will have an extraosseous mass, but it will lack internal mineralization. Another radiographic appearance of Ewing sarcoma, although it's not very common, is called saucerization. And saucerization of the bone occurs when the tumor is associated with large extraosseous masses with periosteal reaction. And then what you get saucer-like appearance. So saucerization is a characteristic appearance of Ewing sarcoma. The tumor actually permeates. The reason why we have large extraosseous masses is because the tumor permeates through the cortex and migrates externally, leading to this large extraosseous masses. And this is why we have extraosseous mass with marrow tumors. Another type of marrow tumor is Langerhans cell histiocytosis. This one also have a permeative or moth-eaten appearance. And this is typically how moth-eaten appearance looks like. It's quite diffuse and permeative. There is very lamellated periosteal reaction. For Langerhans cell histiocytosis is normally polyostotic lesion or pathology, so we would normally do skeletal survey on these patients, or you can do total body MRI to detect multiple other lesions. So it's not like Ewing sarcoma. Ewing sarcoma normally is a solitary lesion, but Langerhans cell histiocytosis, there are multiple lesions in the skeleton, so we always do skeletal survey on these patients. Okay, do we have a candidate? This one may be a little difficult, but we'll
دكتور
we'll
محمد
work on it.
جهاد.
نعم أستاذ، صباح الخير.
صباح الخير.
X-ray of lower extremities show lateral and AP view of skeletally mature bone. There is an irregularity at the and thickening of the lateral surface of the cortex of the tibia with permeative heterogeneous density of the medulla of the tibia. So it look like a permeative diffuse bone lesion with no soft tissue, no soft tissue component, no periosteal reaction, with the wide zone of transition. I suspect this is an aggressive tumor or an aggressive lesion as a general. As differential, it is lymphoma, could be.
Yeah, no, you're absolutely right with the description. I only probably would need to bring your attention back and look at the radiograph, the frontal radiograph again. In retrospect, what do you think of this?
Yes, it is not so clear in my mobile. This is mobile.
Oh, okay. Yeah, okay, that's okay. This is actually an extraosseous mass here. So yes. I can prove it to you on the MRI. This is the same patient. And like you said, the tumor is quite extensive, but we don't really appreciate the tumor on the radiographs as much as we do on the MRI. So you can see the contrast between the marrow fat and the tumor. The tumor is quite extensive. It's taken probably half of the bone already. And there is this medial-sided extraosseous mass here. The signal characteristics, again, are isotense to the muscle on T1, hyperintense signal intensity on stir sequence, and then the mass enhances with gadolinium. I agree, this is a primary bone lymphoma. The definition of primary bone lymphoma is really what is very important here, because the bone can be involved with systemic lymphoma. So how do we know this lymphoma is primary or secondary due to systemic lymphoma? So you need to follow this rule. And the rule says that a primary bone lymphoma is the presence of lymphoma within the medullary cavity of the bone without concurrent lymph node or visceral involvement for at least 6 months following the diagnosis. So if you detected bony changes that are very concerning for primary bone lymphoma, then for 6 months later, there should be no lymphoma in the lymph nodes or the spleen or the liver, for example, because that's the only way of diagnosing primary bone lymphoma. Most of these primary bone lymphomas are actually non-Hodgkin's lymphomas. The distribution of lymphomas, predominantly flat bone, the spine, the pelvis, the skull, the sternum, in about 55% of the cases, but also you can see it in tubular bones, as we saw in this patient. There's another different patient with primary bone lymphoma, quite primitive extension of the tumor here. There's pathological fracture of the neck of femur. Sometimes the radiographs may look normal, and even with this patient here, there's really no bony destruction other than the altered texture of the bone. There is no cortical destruction. It's not like osteosarcoma or telangiectatic osteosarcoma, for example. These kind of tumors destroy the bone completely. But with lymphoma, lymphoma kind of respects the bone. It grows within the bone without destroying it. So this is why sometimes you actually, in patients with lymphoma, the primary diagnosis may not really be the radiographs. Probably need an MRI for these patients because you can walk past them without realizing there is a lymphoma in the bone. Yeah, so again, the cortical destruction can be late. For example, this is the patient we looked at the radiographs. There's this extraosseous mass. The cortex is still relatively intact. There's some preosteal reaction, but otherwise the cortex is not destroyed. And also another feature of primary bone lymphoma on MRI scan is, especially when there's large extraosseous mass and the bone here, when lymphoma grows quite significantly and causes large extraosseous mass, that can actually cause ischemia and necrosis of the bone. So although we did say that the tumor respects the bone, does not destroy it at the beginning, but then when the extraosseous mass becomes so big and surrounds the bone entirely, it causes ischemia and necrosis of the bone, such as in this patient, for example, in the iliac wing. The iliac wing is destroyed because of the ischemia. There's no more blood going into the bone. And because of that destruction of the bone, you get these hypointense linear areas within the tumor, and these are called the sequestra. And the sequestra are a typical appearance of primary bone lymphoma, especially with a large mass like that. The tumor normally enhances. You may get fluid level due to necrosis. Differential diagnosis of primary bone lymphoma in a child, you would include Ewing sarcoma. So in a child with flat bone tumor with large extraosseous mass, you would include Ewing and lymphoma. Osteomyelitis also may look quite aggressive, permeative. For example, in this patient here, you could still say osteomyelitis. So osteomyelitis and lymphoma can overlap sometimes radiographically. Leukemia, metastases, multiple myeloma can also sometimes look like lymphoma. Okay, this is our last case.
دكتورة شيماء.
صباح الخير.
صباح الخير.
صباح الخير.
AP view of arm at the lower arm showing lytic lesion with wide narrow of transition, no sclerotic border, no cortical destruction seen, no etc. Osseous soft tissue extension seen, but the lesion looks to be aggressive looking lesion, mostly just lytic lesion with wide zone of transition, mostly fibrosarcoma. According also, we need the age of the patient. According to the age of the patient may be another differential diagnosis. But the first look is aggressive looking lesion.
Yeah, absolutely. This is an aggressive appearing lesion. There's wide zone of transition. It's quite extensive and permeative within the bone. And this is not a primary bone tumor, actually, although I did the emphasis of this talk is primary bone tumor. This is a metastatic lesion. And the reason why I put this one as your last case is just a reminder that the most common tumor of the bone is actually a metastatic tumor, not a primary bone tumor. So always remember that when you see these lesions, try and remember that metastases can look like anything. And always remember that the most common bone tumor is a metastatic bone tumor. The different types of metastatic bone lesions, but predominantly the lytic lesions are the renal and thyroid, and the sclerotic lesions can be prostate and breast. Okay, so that really summarizes the primary bone tumors talk. It is quite a large topic. Try to make it relevant to your practice and what you normally see. I did not include any rare tumor. There are hundreds of rare tumors, but I did not include any of these tumors in the talk, because ideally the talk should really be about what you normally encounter every day, what you see and how to describe them. What is important as well is that we detect the tumors, we describe the tumors, we rely on the radiographs to decide if the tumors are aggressive or non-aggressive. Again, a take-home message is when you see a pathological fracture or when you see a fracture in general, try and determine whether this is truly a traumatic fracture or is this a pathological fracture. And one way to know about this is actually to take history from the referring physician or from the patient. Was the trauma a major trauma or was it a trivial trauma? If the trauma was major, we're probably just talking about a traumatic fracture. But if the history provided was more of a minor trauma, then you should be suspicious of pathological fractures, because pathological fractures are managed completely different to traumatic fractures. Remember that bone tumor should not be biopsied until you have a discussion with the sarcoma surgeon. And the sarcoma surgeon will discuss with you how to do the biopsy, because normally they excise the biopsy tract during surgery. And they don't really want you to go in a bizarre way and biopsy the tumor, because you may end up contaminating other compartments and converting a limb salvage surgery into an amputation, which is something they don't really want. Most of the bone tumors are referred to bone tumor centers for appropriate management, whether it is a biopsy, surgery, chemotherapy, radiotherapy, and follow-up. I want to share with you this case, and this is really what I was trying to emphasize about the traumatic versus pathological fracture. So this was a patient who presented with a trauma and fracture of the distal femur. Orthopedic surgeons and unfortunately radiologists as well called it a traumatic fracture, and patient went to the operating room and had the fracture fixed with plate and screws, and then patient came for the follow-up radiograph. There was something here wasn't really commented upon, and then patient came back again for another radiograph. There was again this lytic appearance was growing, but again was missed, and then patient presented with this radiograph, which showed a really large tumor. So what happened was, when this patient first presented, there was actually underlying bony lesion, and this underlying bony lesion was missed by the radiologist and by the orthopedic surgeon. So this patient should not have been managed in this way. So when this patient presented with this appearance, this lesion should have been described appropriately, and orthopedic surgeon should have been informed. And then what you do is an MRI scan for local staging to see how extensive this lesion is within the marrow, because most of these tumors, although they look small radiographically, when you do MRI scan, you see quite extensive bone involvement. So the management was completely wrong, sadly, for this patient, who, rather than benefiting from limb salvage surgery, probably this patient could have benefited from an endoprosthesis by excising the femur and putting in an endoprosthesis. Because the surgeons went in and contaminated the entire soft tissue around the lesion, then limb salvage surgery is not an option anymore, especially when the tumor has exploded like this. So this case, unfortunately, ended up in an amputation rather than limb salvage surgery. So the take-home message here really is to always make sure You scrutinize the fracture, make sure that there is no underlying bone lesion, and also take history. Was the trauma a significant trauma or a trivial trauma? This is very important. Okay, so that's the end of our talk. I hope you you learned from it and you take home message from this talk about managing primary bone tumors. And if you have any questions for me, please go ahead.